All right. What about treatment? So, as I mentioned, for the grade ones, there's potential of curing with surgery. There might be examples of where genomics can help. So, most centers nowadays are taking those tumors and doing genomic studies on them because that might be helpful. As a quick example, I mentioned to you that I had a patient a couple weeks ago who had a recurrent polycytic astrocytoma in his cerebellum. So that tumor is still grade 1 polycytic astrocytoma, but it happens to have a BRAF mutation. So if his tumor does recur in a way that is not amenable to surgery, then he might benefit from a very targeted drug therapy. All right, for the grade 2s, so a bit more controversial here. Most would recommend resection, especially if your patient is symptomatic, and especially if you have a patient who's demonstrated growth of that tumor or who has demonstrated signs that might suggest transformation, so maybe the beginning of enhancement. But most would strongly encourage resection. If for some reason you have a patient who might be asymptomatic and it's an incidental finding and maybe doesn't want resection, then you should discuss at least a biopsy so you can at least get that diagnosis and get the genomic data. Because again, those markers there can help with prognosis and help predict response to other therapies. So after resection, radiotherapy is often considered, and that's a bit more controversial. Lots of literature out there looking at that, lots of studies going on, trying to define the role of radiotherapy in grade 2 tumors. All right, let's focus on grade 3 and grade 4 gliomas, the malignant ones. So the standard of care for malignant gliomas was established really in 2005 by this work. And this it refers to the Stoop paper, and so this is called the Stoop protocol. And the therapy is maximally safe resection, followed by concurrent radiotherapy plus temozolomide, followed by at least 6 months of continued temozolomide. So maximally safe resection, so that's important to keep in mind. And then concurrent, of course, means given these two therapies at the same time. And so what you see in this population is basically increased survival by about 2 months in those patients who get that standard of care therapy. So not a dramatic improvement in survival, but nevertheless, there is some improvement. So that's the standard of care now. So centers out there are going to have their own sort of treatment algorithm or scheme, and this is just sort of an example that I'll let you guys go through on your own and look at the details. So the hope is that patients with these malignant gliomas will get through that standard of care. They'll get a good surgical resection. They'll complete those concurrent therapies, and then they'll be able to move on to something else. When you have to modify that therapy, and that's the purpose of my red arrow, is to remind me to say that sometimes you have to modify that therapy, and the various reasons, but the two most common reasons would be a patient who has a poor KPS or performance status, or maybe they're too old, maybe they're elderly and a little bit too frail to go through these aggressive therapies. So you might want to modify your therapy. So I'll say a little bit about that. KPS, so let me just introduce this to you. So throughout neurosurgery, throughout all sorts of conditions, you're going to see various clinical grading scales out there. When it comes to neuro-oncology, KPS is clearly the most common. So this is the grading system, goes from 0 to 100. 0, they're dead. 100 means normal. And you'll see that I circle 70. So 70 is really the most common number that we focus on when we're trying to figure out, is this a patient who can tolerate very aggressive therapy? And what 70 means is this is a patient who can care for themselves. They may not be able to do all normal activities. They may not be able to maintain an active work schedule, but they can pretty much care for themselves. They can be independent. So that number is important also when we're doing clinical trials. So that's probably the most typical criteria used in clinical trials is patients have a KPS of 70 or more. Of course, we want patients to do well in our clinical trials, and most clinical trials are going to select the best patients for that. So that's the KPS or Karnofsky Performance Status Score that you'll see a lot in this topic.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.